Next, I'm joined by Dr. Gregory Lip, Professor of Cardiovascular Medicine at the University of Birmingham in the UK. We discuss Amadeus, development of a novel composite stroke and bleeding risk score in patients with atrial fibrillation. Gregory, thanks for being here at ACCEL. Perhaps we could start by a quick description of Amadeus and then how you've managed to extract the data for this risk assessment.
Thanks very much. Firstly, Amadeus was one of the trials of stroke prevention in atrial fibrillation. This compared a drug called idraparanib versus warfarin. The drug idraparanib has been discontinued and the trial was stopped early because of an excess of bleeding in the patients with AF managed with idraparanib. But this particular abstract or session at the hotline sessions of the European Society of Cardiology is not actually about the Amadeus trial per se, because we were using the data set of the warfarin-treated patients in Amadeus to test a hypothesis. Let me explain this. Because in patients with atrial fibrillation, we are always asked to assess stroke risk. And in the European Society of Cardiology guidelines, and more recently the Asia-Pacific Heart Rhythm Society guidelines, the recommended stroke risk assessment score is the CHADS-VAS score. And in terms of assessing bleeding risk, the European Society of Cardiology guidelines, as well as the Canadian Cardiovascular Society guidelines, recommend using the HAS-BLED score. So we have one score to assess stroke risk, which is CHADS-VAS, or in other guidelines, the older CHADS-2 score. And then for assessing bleeding risk, in the current international guidelines, the HAS-BLED score is the recommended as the best score. So many clinicians say, well, we have one score for this, one score for that. Won't it be really nice to have a single score that will account for both stroke and bleeding events in our patients with atrial fibrillation? In that case, there's some attractions to try and develop such a composite score. However, composite scores can be defined in numerous permutations. In terms of this analysis, which we dealt in the warfarin arm of Amadeus, which was just under 3,000 patients or so, we define firstly a simple composite score, which is essentially stroke and major bleeds. And we also define a complex composite score, which included stroke, thromboembolism, myocardial infarction, cardiovascular death, and then bleeding. Based on those two composites, we derived the predictive factors for those, and based on the multivariate model and appropriate weighing, we then proposed two possible composite scores and tested the predictive value in the Amadeus cohort and also in an external validation cohort of anticoagulated patients from my own outpatient clinic. What did we find? Well, actually, composite score 1, the simple score, as well as composite score 2, the more complex score, which included multiple endpoints, both had pretty good predictive value for predicting the composite endpoints. The C statistic, which is a statistical measure to see how good the score is to predict events, was pretty good. It was over 0.7. A C statistic of 1.0 is perfect prediction. A C statistic of 0.5 is like tossing a coin. So there was pretty good predictive value. The next stage of this is to test whether those new composite scores offer incremental value over the existing simple scores. So we therefore compared the composite scores against CHADS-2, against CHADS-VAS, against the HAS-BLED score, and against a combined CHADS-VAS-HAS-BLED score. And the short answer is that the complex scores may both offer good prediction. They didn't really offer significantly better predictive value over the simple scores that we currently use for stroke risk assessment and for bleeding risk assessment. And in some ways, that's actually a very important take-home message. In your patient with atrial fibrillation, use a stroke score, an established validated stroke score, to assess stroke risk. And in the ESC, we use the CHADS-VAS score as the only recommended score. And in your patient, again, you assess bleeding risk. And in the ESC guidelines, the recommendation is the HAS-BLED score, which has been shown to outperform other bleeding risk scoring systems. There's some misconceptions with regard to the latter, because with HAS-BLED, the high HAS-BLED score is not there as an excuse to withhold oral anticoagulation. The guidelines very clearly say that a high HAS-BLED score is for us as clinicians to flag up the patients potentially at risk of bleeding for more careful review and regular follow-up. And more importantly, the high HAS-BLED score is for us to think about the potentially correctable risk factors for bleeding. For example, the H in HAS-BLED is for hypertension, essentially uncontrolled hypertension. So you control the blood pressure, you reduce 1 point on the HAS-BLED score. And the D is for drugs, concomitant drugs such as nonsteroidals and aspirin, because you add aspirin to anticoagulation therapy if the patient doesn't need it, you substantially increase the risk of major bleeding and intracranial bleeding. So use simple scores, a stroke score for stroke assessment, a bleeding score for bleeding risk assessment. Use them intermittently during the patient review because risk assessment in our patient with AF is a dynamic process.
Yeah, I think that's very interesting data. If you're a clinician and you have to deal with a patient with atrial fibrillation, I think the first message that you made clear was use a score. I mean, there are people still that just don't do a score assessment, and I think the value of using a score, CHADS-VASc, for example, makes you assess the factors in CHADS-VASc. Using HAS-BLED makes you assess the factors in HAS-BLED, so that at least you get educated on the things that you have to check or deal with before or in the process of giving an anticoagulation for atrial fibrillation. So from that standpoint, I think it's important that there are scores, and it's important that people get used to using them. Now, with the electronic record systems that we have, sometimes the score is calculated for you, so you can see it right away. But I think the first point is that learn the scores and use them. Now, your data suggests that perhaps you could refine those scores, but I hear you say now that you don't have to refine them, you just have to use the ones we have. The refinements are interesting, but they don't really add a big incremental advantage. So to me, I think the message is appropriate. It's good data, the scores work, the ones that we have. The more detailed scores also work, but you don't need them. So it makes it a little simpler and a little easier to manage these patients.
Yes, indeed. In some ways, for the last decade, we've been very much trying very hard to identify high-risk patients with atrial fibrillation. And essentially, all the guidelines have, in one sense, been obsessed with picking out high-risk patients because at that time, all the guidelines in terms of anticoagulant therapy, we only had warfarin, which many people perceive as an inconvenient and potentially dangerous drug. So if you're going to give anybody this inconvenient and dangerous drug, you pick out the high-risk patients. But look through all the published observational data, focusing on high-risk patients, there's substantial undertreatment of high-risk category of patients. So in the last few years, we now have alternative strategies for giving anticoagulant therapy with novel oral anticoagulants in particular. And last year in the ESC guidelines, it actually came up strongly recommending a clinical practice shift so that the first decision step in the thought process is actually pick out your low-risk patients. Who are these low-risk patients? They're age under 65 and lone AF, or essentially a CHADS-VASc score of 0, or if in females, a CHADS-VASc score 1. These low-risk patients do not need any antithrombotic therapy because even giving these patients aspirin can be dangerous because of the risk of bleeding, and their absolute risk of stroke is so low. So first decision step, identify low-risk patients using the CHADS-VASc score, and these patients do not need any antithrombotic therapy. Subsequent to this step, patients with AF and one or more stroke risk factors can then be offered effective stroke prevention. Effective stroke prevention is oral anticoagulant therapy. And whether that's delivered as very well-controlled warfarin with time in therapeutic range above 70%, or whether that's delivered as novel oral anticoagulants, that's up to the clinician and up to the healthcare setting. And a change in thinking and change in mindset is needed, that the first decision step is pick out low-risk patients. And subsequent to that, we then offer stroke prevention.
I think that's a good plan for managing the patients. I mean, the first thing we've begun to learn with the newer oral anticoagulation medications is that their efficacy for stroke prevention is pretty good. The thing you worry about is the bleeding issue. And based on the comments you made, the first thing to do is get the patient treated and deal with the bleeding risk as a secondary process. So that makes it a little bit easier to understand how to use the non-warfarin anticoagulants as well. I think it's a very interesting data set. I think your methodology probably can be applied to other clinical trial data, including the non-warfarin anticoagulants as time goes on. So I think we'll look forward to newer studies from your lab. And I'll mention that your study is going to be published in Chest in September of 2013. So congratulations on this nice study. And as I said, we look forward to some other studies in the same area. Thanks again for being here.
Thank you very much.